Good afternoon, everyone, and welcome to our first Fireside chat regarding abnormal vital signs today. We are fortunate to have Dr. Madeline Joseph and Sally Snow, our subject matter experts, working on this bundle with us today, and they're going to do a quick hot topic discussion, and then we will open the lines up for some questions. And if time is permitting, Dr. Kate Remick will be joining us as well to talk about the data system, the entry criteria, a little bit. Dr. Joseph is a professor of emergency medicine and pediatrics at the University of Florida College of Medicine. She is double boarded in both pediatrics and pediatric emergency medicine, and she has authored numerous publications, a bunch of book chapters, and 2 books in the field of pediatrics and pediatric emergency medicine. She's an active member of the American College of Emergency Physicians, the pediatrics section, and has been involved with them for over 24 years, in which she served as section chair in 2007 and the chair of the ACEP pediatrics section consular, and as well as functioned as the chair of the ACEP pediatric committee. She is the ACEP representative on numerous national emergency medical services projects and is a member of our advisory board for the Emergency Medical Service for Children's Innovation and Improvement Center. She is the current president of the Florida chapter of AAP, and vital signs in children are sort of one of her passions. Our second speaker today is Ms. Sally Snow, and Sally is a registered nurse and a certified pediatric emergency room nurse, as well as a fellow at the Emergency Nurse Academy. Sally's been an emergency room and trauma nurse for over 44 years, which has included 30 years specific to pediatric care. She has been both an instructor and part of the development faculty for the ENPC course, which I know many of you have probably taken. And she's served on the Emergency Nurse Association Board of Directors from 2013 through 2017. She, too, has authored and co-authored multiple publications related to pediatric readiness and how facility recognition improves readiness. She was a member of the writing team for the 2009 Joint Policy Statement Guidelines for the Care of Children in the Emergency Department, and was recently part of the team that did the revisions on the new guidelines for emergency department. She has been a true supporter of EMSC, and she, too, is a member of the EMS for Children Innovation and Improvement Center Advisory Board. Thank you both for joining us today, and I'm going to turn this over to Madeline at this point in time.
Thank you so much for the kind introduction, Deanna, and really we're very excited to meet with everyone, even over the phone. A lot of, what we try to do in this next, 20 minutes or so is really to address issues that we are expecting that some of the training sites are going to be asked. So it is, obviously for the people on the call, this is probably almost like preaching to the choir, but really our goal is to help you navigate, what questions you might be asked, and, hopefully give you an opportunity to really discuss things more than anything else. So to start with, and I know this is really basic, like why is it really important to detect abnormal vital signs? Since we're, focusing so much on it, I think the big ask why is really always important to remember. So we kind of divide it to triage and repeated vital signs because those are 2 separate issues. And a lot of times, especially for pediatric patients, if they're being seen in adult ED, the assumption is, they're healthy, they can't be too sick. So, sometimes we're faced with one set of vital signs, but as we all know, just because you have normal vital signs, triage, it doesn't mean it's not going to change. So the triage is obviously to ensure that there's timely recognition of patients with potential or established critical care, and basically we're trying to figure out who's sick and recognize that early because that's the only way we're going to ensure timely and appropriate response from skilled staff. On the other hand, when we talk about repeated vital signs, and that's so important in pediatrics because we know things change, sometime in a good way, sometime in a bad way. I mean, we have kids who look really terrible when they have temperature 104, they're tachycardic, tachypneic, and then they get Motrin, maybe about an hour later, they're, running in the room, they look better. So obviously a lot of these vital signs may improve. On the other hand, we have kids who might deteriorate. So really that's always one of the justification why repeated vital signs are important. And what Sally and I were going to do is, really kind of tag team on this. So, Sally, please jump in as, we're talking to make sure I'm not missing anything.
Okay, thanks, Madeline. One of the things I need to clarify right quick is the slide that we're on. Crystal, I don't see the slide that we're supposed to be on, and I don't have control.
This is...
The slide we need up is why is it important to detect abnormal vital signs?
That's the slide. That's the one that I see.
Okay.
Diana, can you guys see that slide?
I am, yes, ma'am.
Yeah.
Okay,
yes.
Sorry, I'm not seeing it on my screen, so it may be that you guys need to take control of the slide.
Okay.
Okay, so back to the presentation. Thank you, Madeline. One of the things that I wanted to point out about abnormal vital signs is that the ability to detect abnormal depends on your knowledge of what's normal for children at different ages and stages, and as you all know, that changes as their age changes. So some knowledge of normal growth and development helps you determine what is a deviation. And the premise is if you don't repeat vital signs, you can't know if they've changed. A change in heart rate may be an early sign that something's not right. If you don't check it, you won't know you have it. And remember, changes in level of consciousness is also another good indicator.
Yeah.
All right. Next slide.
So we thought, and again, this is really more geared towards, staff and who are not really comfortable with pediatric as much. So this is just a really summary of some of the tricks we learned along the way of how to obtain vital signs in children. Because I know for most of us who take care of kids primarily, it's really not, this is what we do every day. But for someone who's not doing it frequently, it could be a challenge. So my first advice always is you gotta be, the kids always feel your anxiety and agitation. So, take a deep breath and, kind of, be relaxed as you do it, is really important. Involving the caregivers, I think it's a must. One, I mean, the parents want to feel empowered because, obviously they're very anxious bringing their child to the emergency department, and they want to feel like they have some control. So, of course, empowering them to calm their child, and they know their kids best. I think it's really important to remind, staff who are not necessarily used to taking care of children. Pulse ox definitely is helpful because, especially with the repeated vital signs, and because a lot of times, the kids could get used to the sticker on their finger, instead of having to, repeat their heart rate over and over. So I think using the pulse ox could be helpful because they forget about it, and then their heart rate comes down if they're anxious about the whole process. Distraction tools and technology, I think that really could be a hot topic by itself. But I just listed a few of them. I mean, most parents have cell phones, and some of the parents are really astute. They have already downloaded a couple of, games and things like that. So, there is no shame in using technology in such ways. Having bubbles could be, depends on how sick they are, of course. But having even child life, like we're trying to introduce, trying to engage child life even in triage, because sometimes it could be really challenging. But just wanted to introduce the concept of distraction, because I think, more and more, even the little kids are really, very engaged in technology, and I think, using that for distraction could be really a good way to do it. One of the things we were trying to do in our ED to help with patient flow is really trying to move, avoid the bottleneck in triage, so trying to get them to exam room as soon as possible. I know that's not always, possible, but when it's possible, it's probably good to do because it's just less noisy and there's less probably anxiety with it. But again, some of those topics, if there's an interest, we could dedicate more time, for it in the future.
Thanks, Madeline. I can't overemphasize the importance of listening to the caregiver. They're the only person present that knows what a child's normal behavior in response to illness looks like.
All right, Sally. Your phone may have disconnected. Are you still there, Sally? Okay. While she's trying to reconnect, Madeline, I'm just going to go to your next slide, and we'll let her jump back in when she gets back.
No problem. So just wanted to mention an example on, triage. And, of course, probably everybody on the phone is, familiar with the Emergency Severity Index, ED triage. There's a specific chapter, specifically for pediatrics. I wanted to use this one in particular just because I feel like this is very close to what, the adult triage is, and sometimes trying to use some of the same tools, but adding pediatric specific knowledge could be really helpful. So this is just an example. It doesn't mean that's the only one available, but just wanted to mention that because it really talks about, also how do you, the use of resources, which is really important, especially if if the ED is staffed by, few healthcare providers who are comfortable with pediatrics. So this is just an example. And also I wanted to make sure everybody knew that not just the triage algorithm is available, there's really a lot of, good information like a DVD and implementation handbook that is available at no cost. And I think their only criteria is to make sure like there's not, there's no charge for using this material. But I wanted to bring everybody's attention to, a few things because I think this has really simplified the process as much as possible. So level 1, of course, is the highest, and this is where, life-saving if somebody's apneic, and for arrest, that's an easy one because obvious. The next will be, looking at their mental status. Are they confused, lethargic, disoriented, or severe pain? Like if they, for example, they have, let's say, femur fracture or something like that. Those are going to be obvious, where they're going to be brought back and everybody's working on these kids. I think the toughest is when you talk about, level 2 and level 3. And this is where it gets a little bit more challenging. And on this algorithm, I like the simplification, when like it goes by age and also, given their heart rate and respiratory rate. And we'll go through, what could impact these, parameters. But at the same time, I think a lot of time people want like numbers or criteria to kind of use to be able to navigate through the triage process. So I think this is, one of my favorites just because It's kind of simple. It does give, guidance, but I don't want to take away from the, specific pediatric chapter on ESI, with using the pediatric assessment triangle. And, we talked about the general appearance, work of breathing, circulation. But this one, I felt like, if we're talking to an adult ED, folks who are taking care of pediatrics on occasion, this could be a little bit easier, to implement. And Sally, I don't know if you're back on the line or not, but hopefully I covered most of the information.
Hello? Can you hear me now?
Yes, we can hear you.
I'm so sorry. Okay, so I had a couple of really important points to make on that previous slide on tricks on obtaining signs of children, vital signs on children. And one was you can't overemphasize the importance of listening to the caregiver. They're the only person that's present that knows their child's normal behavior and how that child responds to illness or injury. So if they're concerned, you need to be concerned. You cannot blow off their concern. Their definition of an emergency may not always match yours. This is especially true and important when a child has special health care needs. They know what's normal for their child, and that may not match what is normal growth and development for a child at that age. So the other thing is, if you send a patient to the waiting room after triage assessment, you don't have an immediate way to bed them. There's two really important caregiver instructions to give, and that is if you give Tylenol or Motrin for fever control, you always want to instruct the parents to bring the child back to triage for a repeat temp in 30 to 45 minutes so you can see if your intervention worked. The other thing is to always instruct the caregiver to bring the child back to triage if there's any change in the patient's condition. In a child that's ill appearing and has abnormal vital signs, it may be important, it's always important, to get a bedside glucose because that's going to add information to your assessment that you really need. And on the ESI, I just wanted to point out that there is a pediatric-specific chapter, as Madeline mentioned. Triage, of course, when you go back to basic nursing education is, like Madeline mentioned, the pediatric assessment triangle. It looks at general appearance, work of breathing, and circulation of the skin. And you don't have to actually lay hands on a child to observe those things. You want to separate those kids that are sick, the ones that are sicker, and the ones that are sickest. And that's all I had to say on that subject. Thank you.
Thank you, Sally. So this going, and again, our focus is, not for the high volume pediatric ED, but really more of the emergency department that take care of, a few pediatric patients. And this is where, most of the focus of this, talk. So considerations, when we're going to probably pick every vital signs and probably talk a little bit about that. So consideration for pediatric fever. Obviously, the newborn period is always critical. So, from 0 to 28 days of age, the recommendation is to give them a level 2. And this is even if they look great, but if they have a temperature more than 100.4, to give them a higher acuity. 1 to 3 months of age, the consideration is to assign a level 2 for that temperature. And again, even if those babies, because a lot of times, like, the babies look great, and if somebody is not really familiar with the cutoff temperature for a fever workup, they may not say, well, the baby looks great, what are we worried about? So those are really good criteria, for assigning an acuity, based basically on the fever. And then 3 months to 3 years, and again, that's a pretty wide range, but considering given level 3 for high temperature, 102.2, of course, things change a little bit because now we have more children immunized and we have access to immunization registry where we can confirm some of the immunizations. So some of the fever protocols could include, that, in the equation. But I think if there is no such protocols or something like that, just to help with the triage, we want to give a little bit higher acuity for the higher temperature in this age group. The rectal temperature, there's always debate about that, but obviously, rectal temperature is invasive, it's stressful. A lot of parents don't like it, so we obviously don't want to use it if the patient is immune compromised. But at the same time, if there's concern, especially in the younger age group, because you're making a big decision based on their temperature, especially in the first couple of months of life, or if they're critically ill, where it's really important to make sure we have an accurate temperature and that they're not even hypothermic. I think rectal temperature would probably have a role at that point. But in general, just wanted to mention that because I think a lot of parents and, also some of the nursing staff who are not, don't take care of pediatric regularly may feel uncomfortable with that. Any comments, Sally?
Yes. Just that there have been some studies that compared temporal artery and rectal temperature measurements, and they found an acceptable level of variation between the two, but always rectal temps are indicated if the child's critically ill. The other thing I'd like to point out is the Emergency Nurses Association has a topic brief on pediatric fever that was just approved and posted on their website in July of 2018. So if you go to ENA.org and search for pediatric fever topic brief, there's a lot of good information that you might want to share with your nursing staff.
Thank you. And our next vital signs is respiratory rate. And I just want to, for the record, I want to say respiratory rate is not that easy. And it always makes me worry when I get respiratory rates like of 18 or 20, 4 or 5 patients in a row. So I kind of walk to the triage area and say, what's going on? So and want to bring this up, especially in the first couple of months because, most of the babies have periodic breathing. And so this is really good. I counsel the residents on this all the time as well because if they're not going to count for a minute, it really depends on that cycle. They can get somebody who's really pausing for about 10 seconds, or they can get respiratory rate 120. So really that should be part of even the policy is like how do you count respiratory rate, especially in infants, definitely in the first couple of months. But to me, I feel like it's also a good way to do it because a lot of times, like the kids could be anxious, in the beginning, but as you're talking to them and they're getting a little bit more comfortable, their respiratory rate is going to go down. So really doing it for a minute will give the child a chance to kind of get adjusted to the triage area and not get confused with them, with high respiratory rate because they're anxious or fearful. Again, when we look at it, and this is really more for the staff to kind of understand, like, why is it so important to get an accurate respiratory rate is, because it really could be one of the main, signs of the kid is acidotic, if they're in DKA, if they're anxious, if they're hyperventilating. So I'm not, this is not a talk about, increased tachypnea, but I just, wanted to make sure we bring up some of the issues that people always bring up. And it's like, oh, yeah, he has fever 104. That's why he's breathing 80 times a minute. Well, it could be the fever is contributing to the tachypnea, but you can't really account for all that tachypnea to be due to fever. So this is just a reference where, you can increase about, 10 breaths per minute per Celsius elevation in temperature. So that kind of gives a little bit, guideline on, how much fever can you blame the increase in respiratory rate for. Since we're in the flu bronchiolitis season, I wanted to mention suction because, as everybody knew, but just to remind all of us is like a lot of time you're, getting, when you look at the baby first, they may be struggling to breathe, tachypneic, we suction them, and their respiratory rate is back to normal, et cetera. So I think that's something to take into account, especially, during the respiratory season. So this is just a quick things that could change the respiratory rate that, we wanted to mention. Sally?
Yeah, just to add on to what Madeline said about suctioning, when we teach ENPC, we often talk to nurses about how heroic they can seem to a parent who has a baby that's just struggling to breathe, and a simple little suction with a bulb syringe brings the kid back to a normal rate, and the parents think the nurse is a hero, and it's just a little bulb syringe. Assessing respiratory rate can really be a challenge, and we talked about how important pulse oximetry is to vital signs, and this is where it can really give you a lot of information, a lot of help. A good way to assess a patient's oxygenation and ventilation is to look at their pulse oximetry reading. Thank you.
Absolutely. Thank you. And next is the heart rate, and obviously that's going to change with age, and that's the early comment is knowing what's appropriate for the age group, but also activity level, because a lot of time, like if they're hyper, they're running around the room and then they sit down to get their heart rate, that's going to be high. Versus if we get a heart rate of 150 on somebody who's just sitting, 10-year-old who's sitting down and not saying a word. I mean, that's going to mean a whole, that's a completely different scenario. So I think we need to take that into account. Definitely fever will increase, and we'll talk about that in just a second. The fever could increase the heart rate. Crying is really a huge one, we've asked our nursing staff to actually, like, if there is elevated heart rate, to kind of, enter in the comment section of the electronic medical record if the child is crying or not, because we felt like that makes a visual clue, like, that's probably because of that. And at the same time, I think crying is a really tough one, especially in the young ones, so we don't want to underestimate, like, their heart rate is really high because they're crying, because their cry and the nature of the cry could also be indication of how sick they are. And typically, my advice to anyone who's not really familiar with pediatric, like how a cry is a cry, how do you know the difference? I would typically say, like, if the cry is actually irritating you, that's probably an abnormal cry, and because that's usually a high pitch, like more irritable, more like kids with meningitis or really painful sores. So if it's really like constantly and they're not quieting down, no matter what you do, don't just, our advice is not for the nursing staff is not to just be satisfied with saying, their heart rate is up because they're crying. Lack of crying, like, again, it's probably not a bad idea in the policies to say, maybe put a comment, which is part of the triage, like, are they not doing anything? Are they too quiet? Because you expect, like, a 2-year-old to be active, so if they're really sitting there and their heart rate is, 180, I mean, that really should mean something completely different. Pain, agitation, fear, all this category, obviously that's going to increase the heart rate, dehydration, and then the obvious one is, this is when we talk about compensated, shock, and that could be septic, cardiogenic, or hemorrhagic. And like everybody knows, I mean, there's so much compensation with fluid losses till the blood pressure is going to change. So really, a key is to call it what it is. If the heart rate is up with no really good explanation, is to give it a higher acuity. One of the things I wanted to mention, because like at least in where I practice, this is a big deal, especially this time of the season where, since over-the-counter medication co-preparation for pediatric is off the counter, sometimes the parents are telling us that I gave a touch of this, cough preparation, and their heart rate is, 210, and not realizing, some of these medications really are obviously not safe for pediatric. They do cause tachycardia, so those are really good things to ask about as well. So, Sally, any other thing on heart rate?
Yeah, just a word about decreasing heart rate. Some of the things that can cause a decreased heart rate are vagal stimulation, late hypoxia or hypothermia, late shock or cardiac pathology, increased intracranial pressure, and some medicines will do that. One of the things that you have to get nurses that primarily practice in adult settings to understand is that a heart rate of 70 in a child is not such a good thing, where they may be perfectly happy with a heart rate of 70 in an older person or even just a middle-aged person like me. You want to be careful about making them understand or giving them some kind of adjunct so that they can know what normal heart rates at different ages are. Serial measurements of heart rate are very important so that you can validate a child's response to illness and intervention and identify those very subtle changes that happen. And as Madeline said, on the subject of crying, there's lots of reasons a child cries. They're hungry or scared or frustrated or tired or angry. But you need to be able to use that cry to augment your assessment. So like Madeline said, is it weak? Is it screeching or high-pitched? Is it hoarse or low? That might give you an idea there's something going on in the airway. You can tell a lot about a patient's condition from their cry. And as Madeline said, the silent child is very concerning. If a patient is not responding in the way you would expect them to respond, then you need to investigate why that's true. When vital signs are out of normal range and the patient's crying or fussy, as Madeline said, you need to be able to document that so that in the medical record where vital signs are documented, if a patient was crying, it needs to say that so the provider and everyone knows that there is a caveat to those vital signs.
And I wanted to mention, because that's always people blame the higher heart rate on fever. Again, there's a limit to how much the fever is going to increase the heart rate. So this is a reference that talks about, like, you have increased 5 beats, for every degree in Fahrenheit above 100. So that just gives you an idea of how much increase in heart rate to expect with fever. And, anything above that is probably going to be not necessarily because of the fever alone. And for blood pressure, because I think, I've heard it all. It's like, why do we need to get blood pressure in the first 2 years? Because, it's really hard to get blood pressure on toddlers. And then, why do we need to get blood pressure? Like, if they look, great. Really, there's a lot of resistance. It seems like from all vital signs, it seems like the blood pressure, we get the most resistance. And if you think about it, it's not an easy thing to do. You need the right size cuff. Obviously, if it's too small, you're going to get a high reading. If it's too large, low reading. So you have to get the right size. They have to be calm. It's just it's definitely challenging. But in the in the same time, and of course the readings also. What do you do with the reading? Because it's like in adults, there's certain, limits or threshold where above that you'll get concerned. So I think there's many, if you look at the barriers to get, blood pressure reading, I think it's, probably one of the most problematic ones for, for folks who don't take care of, kids regularly. Again, this is, it is according, the normals are per child according to gender, age, height, and it's expressed in percentile, so again, I'm not going to just go through this slide, but just wanted to, mention the challenges, in blood pressure. And I think one thing we probably can add a slide to that is also what is the lower limits, because it's not just the hypertension, because you can probably use, especially with the older kids, some of the adult cutoff, but I think the challenge is the lower cutoff, and we can add a slide on that. But to not to simplify it too much, but if you think of like what is the blood pressure that's, minimum blood pressure that is required for renal perfusion, we're talking about, 60 to 70. So, and that's how I remember it. For the first month of life, anything less than 60, that's not going to be adequate for renal perfusion. Therefore, that's considered hypertension. The first year, less than 70, and then between 1 year to 10 years is the famous formula 70 plus 2 multiplied by their age in years, and for less, more than 10 years, anything less than 90, that's going to be hypertension. So this is just really a slide just to bring up the topic of how hard and the barriers, to getting blood pressure, measured. On the other hand, and I'm just going to jump to the next slide and then give a chance to Sally to comment, is high blood pressure in children, and this is from the American Academy of Pediatrics, and they, advocate for screening, but also that apply as far as the argument to do it in the ED on every patient is a lot of times they can have high blood pressure with no symptoms initially. So this is also our opportunity, to make sure we're detecting any diseases if they have it. Obviously, it could be a red flag for heart or kidney disease. But I think in light of the obesity epidemic, this is something we're going to see more because, like right now, by the age of 7, more than 50% of hypertension is actually due to obesity, and this is just going to, obviously, that's a higher number in teenagers, and from the obesity pandemic that we're seeing, I feel like these numbers are just going to go higher, and it really, we should, make sure we're not missing, these children that have hypertension. From a emergency department point of view is, obviously when the blood pressure start going down, we all know that's never a good sign, and this is where, the beginning of uncompensated shock, and obviously we're trying to prevent that from happening in the first place. So I know you're going to hear a lot of, argument about blood pressure, but hopefully, we gave you enough reasons to be able to be persuasive. Sally, any comments?
Yes, I think you just have to emphasize that blood pressure is a vital sign, and it's important, and make it an expectation that all children have a blood pressure taken. One of the things that I've seen nurses use in triage as a technique to make the child more comfortable with blood pressure is to ask the parent if you can take their blood pressure, and so the child sees that it's not something that's going to cause them pain. You can tell them that you're going to give their arm a hug or their leg a hug, and it kind of demystifies the whole thing and makes it much easier to measure. And as Madeline mentioned, hypotension is a late sign of significant fluid or blood loss in a child. It's the last thing you're going to see drop. They can compensate for up to 30% volume loss before you'll ever see any hypotension. And on a personal level, if you don't measure a child's blood pressure, you may not know they're hypertensive. My husband's first blood pressure at 16 at a football physical is where he learned that he was hypertensive, and he's been treated for hypertension ever since. So if you don't check, you won't know.
Absolutely. So just to kind of put it together, for emphasizing, why we need to pay attention to abdominal vital signs. And again, I think in almost every ED in the country, there's always talk about septic shock, even sepsis protocol, et cetera. So I just again, we want to empower you with the tools of how do you address this. It's like, so again, pediatric patients, they're at risk also for septic shock. It's not different from adults where our priority should be to improve recognition of shock. And the only way we're going to start doing that is by identifying a patient with abnormal vital signs. Again, when you're having these discussions, you're creating a system. So you want to make sure there's no variation in the ED. If you're going to attack, sepsis in the ED, that should be for all age group, and that includes, pediatrics. This is always the message that you want to, help advocate for the children. One of the things that, is happening, and especially with the electronic medical record, and it depends on how sophisticated, the septic protocol is and if it's associated with the EMR. But regardless, whatever system we have to make sure, like, the criteria, to what's considered sepsis is actually pediatric specific, and those whatever criteria is going to be used should be also in the vital signs policy or guideline. So just to kind of close the loop, I wanted to bring an example of septic shock recognition. This was really a great article that was published in Pediatrics a while ago, actually a couple of years ago, but I would definitely encourage you to read it because it's not just, what they were able to accomplish, but also how they went about it. And, that all started with a triage algorithm and specifically, mentioning, like, what do they consider fever, as simple as that, what are the risk factors, what are they, what I like about it is also, attributing, if you're going to say tachycardia, that's one of the things you're going to, associate with sepsis. You can account for the fever, et cetera, like what we mentioned earlier. So this would encourage you to really look at it in detail, just to look at their protocol, because their messages, like, septic shock recognition in children does matter, and the result of that study was incredible, because just by implementing that protocol, they were able to cut the time from triage to the first bolus from 56 to 22, which is amazing. And then also decrease the time, from triage to the first antibiotics from 130, which is, if you think about it, this is really a long time, to 38 minutes. So if you need any evidence, like, having these protocols and having these criteria really can save lives, I think, this is really a good article to demonstrate, like, how it really impacts, outcome. And one of the things, I've strongly believe in success in developing any protocol, but I think the way they developed the sepsis protocol is really recognizing that everybody that the need for improvement is actually acknowledged by all stakeholders, and really use that, concept and principle, because, if we're not engaging, hospital administration and staff and leadership, that this is a quality improvement, it's a must, because, we can really save some lives, even if they're not that many. But each one count, and really take it from the point of view is we cannot have different standards for sepsis protocol, depends on the age. We cannot have that. So this is, so kind of push the envelope, through that line of thinking. Again, the collaboration and flexibility and the feedback, even if it means like you call the transport team sooner, or you initiate the transfer sooner, whatever it is. It doesn't have to be collaboration or flexibility within the same hospital. It could be between the referring and the receiving hospital. But as long as those communication lines and those protocols, everybody that's involved in the pediatric care and is really on board, I think is going to make a huge difference. So any comments, Sally? I know I went through the substance protocol, but wanted to put the whole thing together.
Yeah, the only thing I wanted to mention, we could get to it later in the presentation, but is the importance of looking carefully at your vital sign ranges. Whatever policy you decide to adopt as your reference for normal vital signs, your EMR needs to match that, so that if you have a vital sign fall out of the normal range, in the documentation system, it alerts you that that's out of the normal range. I know in a hospital I worked at many years ago, or not that long ago, there were some discrepancies in the EMR vital sign ranges versus the vital sign ranges and accepted normal ranges in the emergency department. And we didn't even know it until somebody just happened to catch it. So it's really important that everybody knows what the normal range is, the policy establishes that normal range, and the EMR reflects the same normal range. A way to help your staff recognize that vital signs, what the normal vital signs are, again, is that badge buddy for normal vital signs by age. Thank you, Madeline.
Perfect. Thank you.
So, Madeline, what we'd like to do, since we still have a couple more minutes, can we open the floor up to questions?
Absolutely, because I think the rest of the slides is, really more of, some of these strategies. But I think I think it would be really good to discuss and address any issues.
Okay. So callers, what I'm going to do is unmute all of your lines now, and feel free to ask the subject matter experts anything that comes to mind based on the content we've covered today.
So, I did it. Yeah, I didn't try. Sorry, it's 99.
Any questions? Okay. So
Crystal,
go ahead.
If I could just plug education for nursing staff. It's really important that you provide your nursing staff with some education on how to take care of kids. And I'm just going to plug the emergency nursing pediatric course as one of the more comprehensive courses that teach you all kinds of important things about taking care of kids, not just resuscitation. Thank you.
One of the questions that came in is when a child's vital signs are are noted to be abnormal, could you provide examples of how to integrate notification into the ED flow?
Well, I think that should be addressed in the policy, because how you communicate is going to be important, but everybody should do it the same way. So, for example, we use Epic as our EMR, and if I have a child with the heart rate 180, it's going to show red, in Epic with exclamation point. So it's given me a notification, but there's really we're working on trying to have maybe some of one way for the nurses to send the message, but that's really hard in the ED. So I would say it depends on, because you don't want to have fatigue, alarm fatigue either. Does that make sense? Because you can. So I think it's really good to have a policy where, the nurses are, let's say it's 180, but they have fever. They already have protocol in place to give antipyretic. Depends on other things in triage. They may, increase the acuity. They may want to, if they're uncomfortable, to get the provider to take a look at the child. So I think those are the type of things I think they're really good to put in a policy. So, one, it works for the individual ED, and depends on the staffing and all that, and but also it makes it unified, so everybody is responding to abnormal vital signs the same way. So we cannot just rely on electronic medical record, because I think a lot of time like I said, there's alarm fatigue with just you're getting all these, signals, and it's really hard to respond to all of it. But at least for the provider, it really heighten your awareness, like, okay, this is a sicker kid, I really need to go and probably see first before, the next one.
So we have another question. We know that some facilities have different standards for vital signs. What would you recommend be defined as a normal set of vitals, and then when should we add additional components?
So in some of the slides, we did, there are definitely standards for normal vital signs ranges. And that we have some of those definitely references listed. So PALS, Pews, Apples, Harriet Lane. But they're really not, which is really surprising to me. You would think like we have consistent ranges for normal, but that's really not the case. It really does vary from one reference to another. But I think that's why it's really important to decide, for the hospital, what are you going to consider normal vital signs, and everybody uses that range. And then that should be the one that you use for, throughout the organization, but also in the 3S policy or guidelines. But those are actually listed on the website, right, Deanna? I think that was some of the references we provided.
Yes, those are listed there.
Sally, any thoughts about that?
I just think that the point is that you, as an organization, and your leadership team in the emergency department needs to decide what reference you'll use as normal vital signs, and then that needs to become part of your policy, and if necessary, a poster or a badge buddy that gives everyone the same reference for normal. I think we've said that heart rate, respiratory rate, temperature, blood pressure, and pulse ox is a set of vital signs, and that's what should be adopted. And there should be a good reason documented if you're not able to obtain one of those vital signs.
Thanks, Sally. Any other questions from our participants? We know that if you are joining today's call, you're probably going to be working on Bundle 2, which is abnormal vital signs. Do you have any questions for the subject matter experts or the admin team related to this bundle?
If I might just say a comment, we're definitely, wanting to make sure whatever we cover is what you're really looking for, because there's, like Sally mentioned, there are courses on, pediatric triage and assessment, but, it would be for future sessions. If there's any specific questions you would like us to explore, by all means, please do, because we want to address, we want these sessions to be helpful to you.
So as a couple reminders, we know we have about 6 minutes left with everyone. We have Fireside Chats still scheduled for the month of February. What we will have is disaster planning on tomorrow at 11 a.m. Central, and then weight and kilos will be on February 19th at 12 p.m. If you have any questions, we will be, please send it to your trainer or send it to QECA@texaschildrens.org. We are recording today's session, and slides will be posted to our website. Kate, Diana, any closing remarks?
No, just thank you very much, Sally and Madeline, for at least getting us started thinking about vital signs. Seem to be a rather easy topic for most people to think about, but they are extremely critical to every child, and how you define them at your institution is going to be very important as you move forward with identifying when is the right time to escalate that child's care needs. That's all I have. Thank you, though, both our speakers.
Yeah, I just want to say also thanks so much to both of the speakers. And then just if you have any questions about the bundle, remember that there's an intervention bundle guide, which is available on the website. You can go back through that and walk yourself through the various data variables and the metrics that we'll be looking at. I know that Sally and Madeline had planned to go over that a little bit, but we ran short on time. So if you have any questions about those, please feel free to reach out to us. And then in addition, as you heard, there are references to ESI, standard vital sign guides and the like that are on the website. So also feel free to look that over and email us if you have any questions. So thanks so much to everyone for joining today. And thank you to Madeline and Sally for your time today and your wisdom.
Thank you.
Thank you guys. Always available if you need anything.
Absolutely. Thank you for having us.
Thank you.